congratulations to the organizers of the second echocardiography conference at the national level. Strain, Professor Tahin has made my job a bit easier by emphasizing on strain a lot. Although it has been used for 22 years now, since its inception in 2004, but still it is a very less commonly used modality for various reasons. Number one, the software is not incorporated into the usual machines that we use. Secondly, there is not much know-how. And thirdly, in our country, we don't have the normal values for strain measurement. We conducted a study, my group conducted a study, in which we analyzed the normal transthoracic echocardiographic strain measurements in Pakistani adults. This study is still ongoing, and this I am presenting an interim analysis of the first 100 patients. The study is unique in this regard that it is the first large-scale study on this topic. Secondly, we are doing strain measurements by dedicated software for each and every cardiac chamber. We are not overlapping. We are not using LV for LA or LA for RA. No. We are using dedicated software for each chamber separately. So this is the uniqueness of this study. But first, some of the basics of a strain that, as you know, heart is a mechanical organ, and its efficiency is measured by echocardiography. Mostly EF is the parameter of value which is noted in every echocardiography report. But it has got limitations, as eyeballing is frequently implied, as you have seen, that requires a lot of geometrical assumptions, whether LV is prolateral ellipsoid, or is a cylinder hemiellipsoid, or it is a stack of discs, and difficult mathematical formula, like the method of disk summation. And a compromised EF usually signifies a point of no return. Variability, both inter and intra-observer, is too much, and it is exclusively load dependent. So we need another parameter by which we can assess the mechanical performance of the heart, and that is deformation imaging or strain. What is a strain? You see a muscle, it can having a resting length of L0. It can be acted upon by two forces, either external, in which it lengthens, or internal, that is contraction, in which it shortens. In every case, there is a change in the length, and it assumes a new length of L1. Strain is just the new length minus the original length divided by the original length, expressed as percentage. Now, if the length increases, the strain is positive because L1 is higher than L0. If the length decreases, this is a negative strain because L1 is now less than the L0. Both of these are used in our strain assessment, mostly negative strain for LVRV and positive strain for LARA. We will come to it. So how strain is obtained by echo? Here we need the concept of speckles. We throw ultrasound waves into the body of the patient or the subject, and some of it is reflected. Most of it gets refracted because of destructive and interference of ultrasound with the body tissues, creating dots. These you have seen in your 2D echo images. These dots move. These dots are known as speckles, and they comprise of 20 to 40 pixels. Group of speckles is known as kernels. Now, movement of these dots can be evaluated for the velocity and the distance, and these can be analyzed by specialized software like fast Fourier transform analysis or sum of absolute differences algorithm. We will not go into the detail of it, but that shows how much the dots have moved, so how much contraction has occurred or how much relaxation has occurred, so that we can detect positive strain or negative strain. Another concept in this regard is the three-layered arrangement of biofibers in LV. As you know, the fibers in the inner layer, they are more vertically oriented, making an angle of approximately 80 degrees with the horizontal. They, when contract, they produce longitudinal contraction, and they are responsible mostly for longitudinal strain. As the fibers wrap around the circumference of LV, they become more obliquely placed, making an angle of 60 degrees, and now their movement will produce radial and circumferential contraction or radial and circumferential strain. So now, in this way, we have divided the contraction into three phases. This is the advantage of strain over ejection fraction. This tri-layered arrangement is complementary, and EF being the combined end result is not affected as decreased performance of one layer is offset by other. And subendocardial fibers, as you know, are subject to ischemia the most, are affected first. So longitudinal strain shows a decline first before ejection fraction declines. Zito has recommended in 2018 that currently GLS is considered the most accurate and sensitive parameter for the assessment of early left ventricular dysfunction before EF declines. How we do it? We get 4-chamber apical, 2-chamber and 3-chamber views, good quality, put an ROI over it to encompass the myocardium, and then the software is started. Each view has got 2 walls, and each wall is divided into 3 segments, base, mid, and apex, so that overall we have either 16 or 18 segments, depending upon the division of the apex, either 4 or 6. Each segment is represented graphically by a separate color, as you can see over here, by a separate color. And as the LV contracts, the strain becomes more negative. And the average of each view is given by the software, and the average of 3 views are summated to give a bull's eye view, like this. And the graph, or in a tabular form also, the software gives the average value for each chamber and for global value as well. The outer circle or in the bull's eye view shows the basal segments, the middle circle shows the mid segment, and the inner circle shows the apical segments. For left atrial strain, again, we put a region of interest, but left atrium has got 3 phases, and these are corresponding to the left ventricular contraction. As LV contraction starts, the mitral valve is closed. Blood cannot go into LV, but it is coming into the LA through pulmonary veins. So the size of LA is increasing. In this way, we have got a positive strain, which is known as reservoir strain, in which blood can come into LA but cannot go out. Once the mitral valve opens, blood gushes into LV, the size of the LA decreases, and this is known as conduit strain, which is a negative strain. And thirdly, when atrium contracts, it further reduces the size of LA, and this is known as contractile strain. So in LA, we measure 3 types of strain. The right ventricular strain is measured in the same way as LV, but here you must direct your focus towards RV. It should be taken in an RV focused view. I learned how to take good quality images by doing a strain, because in a strain you need very good quality images. So, but here in RV, we assess 2 walls, the RV free wall and the septum, and each being divided into 3, and the machine gives you the global value as well as the RV free wall. And RV free wall is more important. RA is done in the same way as LA, like reservoir strain, conduit strain, and contractile strain. So, a group of carcinologists measured the robustness of strain measurement, especially GLS, as compared to other echo parameters. There was just 4.9% intra-observer, and 8.6% inter-observer variation in the measurement of GLS. And this group also measured what was the mean error in measurement of different echo parameters. And you can see here, GLS has got the least mean error of measurement. So it is the most robust parameter for assessment. So coming to the study again, the background was that WASE, World Association of Society of Echocardiography, who are repeatedly producing results for the dimensions of various chambers of the heart internationally. I think 16 or 17 countries are included in it. Our country is lagging behind. They mentioned that there is significant intercountry variation for all LV parameters, and intercountry variation for LVEF and GLS was small, but still statistically significant, and they recommended normal strain measurements for every nation. This was the basis of my study. Secondly, I have told you strain values of adult Pakistanis have not been reported till date. ERB approval was taken, and we measured these things. Strain measurements of all 4 cardiac chambers, the LV, GLS, and strain of 3 views, along with the strain rate. RV free wall and global strain. Free wall is important. LA reservoir, conduit, contractile. Reservoir and contractile are important, and more so reservoir. Similarly, RA reservoir, conduit, and contractile. Again, RA reservoir is important. Intra and interclass correlation would be done for robustness of study. And this study would be completed perhaps in a year, which I think not so. It may take more time. And For the present, I am presenting just the first 100 cases. The results would be compared between groups, gender, ethnicities, and with international data. So the groups were, we divided them in according to age. Group A, 18 to 40. Group B, 41 to 65. And Group C, the elderly, greater than 65. Each group has got equal number of female and male, and equal number of participants from the 5 major ethnicities of Pakistan, that is Baloch, Pashtuns, Punjabis, Sindhis, and Urdu speaking, making a total of group of 150 and a grand total of 450 for the whole study. But now, till now, we have recruited 100, of which Group A comprised of 53 subjects, Group B we have done 36, and Group C we have done 11. The demographics, clinical and lab parameters are not significant between the groups except for BMI and BSA and the creatinine, which was higher, bit higher in the elderly, not in the pathological range. The routine echo measurements were also not significantly different except for TAPC, which was higher in Group A as expected, and the Doppler parameters were also not significantly different except for A with reversal of E over A in the Group C patient because of age, and E dash average was higher in the Group A younger patients, so E over E dash was also higher in that group. This is important now. What our study shows. The strain data. Average GLS in our population came out to be minus 19.8 plus minus 2.1 with no difference, significant difference across the 3 groups. I will just show you the salient strain features. Average strain rate is minus 1.2 plus minus 0.2, no significant difference across the group. LR reservoir was 38.1 plus minus 10.4, no significant difference. RV free wall was minus 25.3 plus minus 4, and RA reservoir is 35.2 plus minus 9.9. It is a bit significantly different across the group because of lower number in Group B, which we are looking the cause of. This is very important. The range is there. What is the normal limit of normal? What is the lower limit of normal? So for average GLS, we have found in our study that minus 15.7 is the lower limit. That's why I asked that question. The average strain rate is minus 0.81. LA reservoir is 17.7. RV free wall is minus 17.5. And RA reservoir is 15.8. These are the values that we have got. And I think that would not be much difference as we complete the study because 100 is a good number. And usually these studies are done with 100, 110 subjects. But since we have taken the 5 ethnicities and we want to have each and every group adequately represented, that's why our number is 450. With regard to gender comparison, there is not much significant difference between male and female, although females show a higher, not significant LVGLS, and males show a higher LA reservoir, not significantly different. Less are also okay. When we compared our results with international studies, mixed results have come. Like for LVGLS, our value is minus 19.8 plus minus 2.1. And when this was compared with Japanese study, there was not much difference. P-value was 0.547. With a recent Norwegian study that has been reported just last year, it was 0.207, not significantly different. But when we compared this with 2 earlier studies from Korea and 1 from America, there was some significant difference. Average strain rate, our value compared with Korean study showed no significant difference. LA reservoir, our study 38.1 plus minus 10.4 was significantly different as compared to a Korean study and also with a Norwegian study. This Norwegian study is just reported last year. RV free wall is 25.3, and this is significantly different as compared to a study available from Denmark and not significantly different from the study done by Norway people. RA reservoir was significantly different as compared to Iranian study and also from the Norwegian study. So you can see that a mixed result. So Way's emphasis is very eminent that we must know our own national level, our own national number. Inter-ethnic comparison cannot be done here. In conclusion, this interim analysis of strain measurements in 100 Pakistani adult ascertains the normal values of all 4 cardiac chambers in our population for the first time, which can be used for routine clinical application. With this, I thank you very much.
Thank you very much, Dr. Imran. I think it's a good effort, but if you looked at the numbers in the different nationalities, there's hardly any. There's a range which you always have in normal strain, and that is nearly the same in most of the nationalities that you showed here. The other thing is that the heart, whether it is of a Japanese heart or a Pakistani heart, the fibers, they are arranged in all the 3 directions in a similar manner. And therefore the strain is not going to be much different. That is my first view about it. That this is what I think that we are probably, what we are doing is, I don't know if it is correct or not, reinventing. And the other thing is that, like Dr. Tipu said yesterday, we need to have the normal controls, not the patients who come to us. And then we measure their strain and say that since this patient is normal, so this is the normal value for the strain. So I think we can take this data, but with a little pinch of salt. If there are any other questions from the audience.
Just first one comment. It was an excellent study, I think we must appreciate Dr. Imran Hameed for doing such a nice work. And the question is that from where did you take the patients? The subjects. Were they the actual patients or were they the normal subjects taken from the population?
This is a very important question. And I think that will clarify Professor Shabazz also. These are not patients. No way we can take patients for such a study. These are normal subjects, like any normal person. And they were screened off first for the presence of any disease in their entire life. And that's why the number you see in the elderly age group is a bit lower till now. Because by the age of 65, it is very difficult to find a normal person. Believe you me, it's very difficult. Although this group comprises only 6% of the population, but it is very difficult. And you cannot imagine the frustration that we get. We have to do all the routine lab, we have to do the clinical examination, and we have to do the BMI, BSA, and many of the subjects just fall out just because of BMI being 30.1, 30.2, because we cannot take above of 30. And thirdly, hemoglobin. This is how I came to know that hemoglobin is so low in many of the patients, because my cutoff was normal is 12.5. And even if it is 12.4, 12.3, we have to exclude it. And so many of normal subjects, they don't have even normal hemoglobin. So we were finding a lot of patients while doing this study. So to go into the study and being declared as normal, it was very, very difficult.
Imran, the other thing is that you will not always get a very good echo in these patients, especially who are obese also. And there you will not be able to identify the endocardium as clear as possible to get a proper strain imaging.
One slide that I should have put it in is the inclusion criteria and the exclusion criteria. These were all the exclusion criteria. If you are not getting good quality images, we will exclude it. We have excluded.
Thank you very much. Your presentation was very good. It is provocative.
Sir, excellent presentation, Sir Imran. I have got two questions. One, which software you used for this study? Because we know there is an inter-vendor variation in the normal values. So my question number one is, my second question is very stupid question maybe. What's the correlation of the regional wall motion abnormalities and these this global longitudinal strain bullseye picture? Can we use this bullseye picture which we get on the global longitudinal strain to identify the regional wall motion abnormalities as well or not?
Professor Tawheen has also mentioned that GLS she has taken to detect ischemia. Now, with a very high sensitivity and specificity, 80%, 90% figures in like that. For regional strain, I will not really endorse at present because the sensitivity and specificity are in the range of 50 to 70. Sensitivity a bit higher and specificity a bit lower. I don't remember the exact percentage. For regional, that you can identify that see, this is mid segment of mid-interventricular septum is disease. You cannot do that. But average GLS will give you that there is ischemia, yes. And if this give you in the ER, that is very good. About your first question, which software I'm using this Canon Applio i700 machine. The software is incorporated into it. And I've come to know that this machine, I don't think so it's available anywhere else in Pakistan except for me. And about the interventor variation, very good question. There was a study conducted in, I think, Germany, and they compared 7 machines with each other, about 47 or 48 subjects. Same subjects were rotated and were examined by all the machines, and then they found how much is the difference. So hardly 2 to 3% of the difference if this is done accurately. And nowadays, it's with latest machine. This study was also done, I think, 2015 or 16, a bit.
Thank you, Imran.
Right.
Yes.
Thank
So,
you, Imran.
thank you.
What Imran is saying is about very recent study. Previously, there was differences. Now, please
Thank-
go ahead, Shabazz.